Thank you. Good afternoon, everybody. The last session before lunch, I shall be brief. The talk that has been given to me is anticoagulants and regional anesthesia. So most of the things, the adverse outcome of improperly performed neuraxial block or a peripheral nerve block in a patient with an anticoagulants, Dr. Rashekar already has summarized, and we have been hearing to all this yesterday. Also, we had some deliberations on this. I shall just take you through some of the commonly associated problems which we encounter routinely in our clinical practice when you have a patient with anticoagulants, associated coagulopathies coming for regional anesthesia. Basically, most of the patients who are on anticoagulants, either they receive anticoagulants for prophylaxis against DVT or for prevention of venous thromboembolism or for treatment of DVT and treatment of venous thromboembolism. Or sometimes these patients have prosthetic heart valves or coronary stents and they need antiplatelet agents and anticoagulants for prevention of coronary stent thrombosis or perivalvular thrombosis following a prosthetic valve. Or sometimes we use in the perioperative to improve the perioperative outcomes in terms of minimizing risks of DVT and pulmonary thromboembolism in patients with inherent thrombophilias. Well, I don't have to emphasize to this elite audience about the advantages of regionals, but the fact remains that the regional anesthesia in today's practice has a very established role in terms of preventing major patient morbidity and mortality, and also improves patient satisfaction. And the two areas which I would like to emphasize, which has improved the patient outcome, is geriatric patients and obstetric patients who come for operative surgeries and pain management. And in fact, in obstetrics, the mortality and the morbidity, I would say morbidity is 17 times less when compared to general anesthetics. So we don't have to discuss much on this. Why are we worried about this talk on worried about anticoagulants and regional anesthetics? Basically, if you see conventionally, the risk of neuraxial hematomas or peripheral nerve-related hematomas are less than 1 in 1,50,000 following an epidural and 1 2 lakhs following spinal. Very rare events. In fact, the spontaneous incidence is much more than a block-related incident. But when the patient is on anticoagulants, when the patient is receiving various types of antiplatelet agents, this risk increases on a logarithmic scale. It almost goes up by proportionally to 1 in 3,600, which is very, very high, and we have to make all attempts to minimize. In fact, to confuse the matter much more, there is an entity called a spontaneous neuraxial hematomas which are reported in patients on anticoagulants. So whether your procedure definitely adds to this insult and can further increase the problem. So here we have a patient. What are the problems? The risk of spinal hematoma, the risk of peripheral nerve hematoma, unplanned surgeries with anticoagulants coming for emergencies, and we are not certain what technique we need to use, whether to use a plexus catheters or single shot techniques, or whether you want to use ultrasound guided techniques, which are better, which are superior. What am I familiar with? The most important, everybody says ultrasound, peripheral nerve stimulation, but I must not, several of us must not have used ultrasound at all. So we need to be, several things are involved. And many times newer anticoagulants are come in the market, and the commercial market is so strong that the representatives, they mislead you, saying the pro and con of each, and you as a clinician, you are held responsible if something goes wrong. And most important, the true incidence of hematomas are unknown. So definitely it poses a significant challenge. There are several recommendations, and there is paucity of data and paucity of RCTs for ethical reasons. So to form so good guidelines so as to prevent or minimize adverse events or maximize safety in regionals, we have guidelines, and several associations have formed several guidelines. And to confuse more, to our dismay, we have guidelines from ASRA, guidelines from France, guidelines from Germany, Austria, Belgium, Netherlands, and everybody, there is subtle difference, but there are several guidelines. If you see the ASRA guidelines which we all follow, there have been 3 consensus guidelines in 1 decade. So it just means that we still don't have, and we are still on a blind path. But yes, several reports and review of small case series, we have certain guidelines which I shall be discussing today in my talk. And the bottom line is maximizing safety. Well, before we go on to this, let us see what anticoagulants or antiplatelet agents we have or we use in clinical practice, and when the patient come to us. Either they are on heparin, the unfractionated heparin, the low molecular weight heparin, antiplatelet medications, oral anticoagulants, herbal preparations. Many of times we have a habit of swallowing multivitamin pill, and we don't know what are the composition of that pill, and we end up with problems. And as I said, newer anticoagulants, they come into vogue very often. And many a times these patients are either, these medications are used either for thromboprophylaxis, for therapeutic, or as a preventive measures, which I said earlier. So what are the specific anticoagulants in the, that is recommended for the patients, and how do we titrate them perioperatively? Well, coming to the first and foremost, which is one of the most common agent, is antiplatelet agent, and aspirin is one of the most commonly agent that almost after age of 40-45 years, every cardiologist would be very happy to give aspirin to everybody. Anesthetists, all anesthetists and all surgeons, they use anesthetists left, right and center perioperatively. The thienopyridine derivatives, the clopidogrel, ticlopidine, again most of the patients, again beyond the age of 45-50, even slightest chest pain or any transient ischemic episode, they put them on antiplatelet agents. And if this patient comes for some surgery, we have had it. And the newer agents, they come into market. So aspirin, as I said, they are, I don't want to go into the mechanism, but they are COX inhibitors, irreversible, and the duration of action is 10 days. But generally, the perioperative use as the standard guidelines, we don't have to stop aspirin before surgery, and even NSAIDs can be given carefully. But yes, when you are giving aspirin plus NSAIDs plus heparin, then you have to be careful, and you need to remember that you cannot monitor aspirin activity by bleeding time, clotting time, neither PT, APTT. You have to be careful. Many a times we do send by the knee-jerk reaction that BT, CT, PT, APTT because the patient is on aspirin, but this serves no purpose. You are just wasting resource and money, and you can use it in some other area. So whenever you have a patient on one antiplatelet agent, it is always better to look for any concurrent medications the patient is receiving, and also you need to know any other additional history which points out to any bleeding diathesis like easy bruisability, excessive bleeding, female gender and increasing age are excessive risk factors. So as an anesthetist, our prime or single most important thing which we need to do is minimize bloody taps, minimize multiple attempts, and make your procedure as atraumatic as possible. Coming to thienopyridine derivatives, we have clopidogrel, we have ticlopidine, and generally the standard recommendations, they say that if the patient is on clopidogrel, it's a long-acting agent, you need to wait minimum of 10 to 12 days, 14 days is what they recommend, and this is a safety limit which we need to follow. And if the patient is on clopidogrel, or even there are newer ADP inhibitor which have come into vogue, prasugrel, you have to wait for at least 7 to 10 days, but minimum 5 days is what is recommended. And there are no acceptable laboratory tests to detect their activity. Again, BT, CT, PT, APTT should not be ordered unless you have some other cause to think of. The GP3A inhibitors, again abciximab, eptifibatide, and teriflunomide, again many patients with acute coronary syndromes, they are on these medications, and you need to be careful because they often have a half-life of almost 24 to 48 hours, and sometimes even for beyond that, and there are no clear-cut literature as to safety of regionals in patients on this medication, so you need to tread a safe path. Especially if the patient receives GP2B, GP3 inhibitors post-operatively for any acute coronary syndrome which happens in the post-operative period, you have to put this patient on a safety net so as to detect the problem early and you can intervene appropriately. Oral anticoagulants are other common anticoagulants which we see in our clinical practice. Generally, the coumarin derivatives, warfarin or comedins, they inhibit factor vitamin K, and the vitamin K dependent coagulation factors like 2, 7, 9 and 10 are inhibited, and PT-INR is a standard modality by which you test the activity. Generally, when you are starting anticoagulants, it takes about 4 to 6 weeks to stabilize the therapy, and initially the PT-INR values may be unreliable, so you get a true reading only after about 4 to 6 weeks. Few things which you need to know about warfarin is, remember that warfarin inhibits factor 2, factor 7, factor 9 and factor 10, and if you see the half-life of different factors, the half-life of factor 7 is just about 6 to 8 hours, and factor 9 and factor 2 is quite high, like factor 10 also is quite high. So almost you need to remember that when you are checking this patient with PT-INR, they don't give exact reading, because during the first few hours when you initiate the therapy, the factor 7 activity initially starts and it may raise INR, but you may still not have effective anticoagulation, vice versa. If you stop this medication before surgery, within 24 hours you may have an INR of 1.5 or less than 1.5, but if you see the half-life of factor 9 and factor 2 are still high, and you may not have a safe patient in the perioperative period to perform a regional block. So whenever you have a patient on oral anticoagulants, remember that these are all the things which you need to remember before you decide to perform what type of block and what block. So ideally, warfarin needs to be stopped at least 4 to 5 days before surgery, and review any concomitant usage of any other medications. And coming to other types of anticoagulants, the standard heparin, the unfractionated heparin, again it's the antithrombin 3 agent. It neutralizes activated factor 10, factor 11, factor 12 and factor 9. The duration elimination half-life is just about 60 to 80 minutes if you are giving parental route, and if it is subcutaneously, then it's about 4 to 6 hours. And if the patient is on mini-dose heparin, when I say mini-dose heparin, the patient is on prophylactic dose of heparin, the dosage the patient receives is less than 10,000 units per day, and you can safely perform a neuraxial block, epidural block or a spinal block without much of a problem, unless the patient is receiving on any concurrent medications. But suppose if this patient is receiving more than 12,000 units per day, like 7,500 BD or 5,000 TID, then you need to be cautious, because even subcute administration 8th hourly of 5,000 units can cause deranged APTT, and you need to tend caution. Generally, for most important thing which I said is you need to minimize blood tap. For some unforeseen reason, if you have a bloody tap, it's always better to communicate with the surgeon, because if the surgeon is contemplating to use heparin again during surgery, like if you are doing a femoropopliteal bypass or any peripheral vascular surgeries or major vascular surgery, and you had a bloody tap during a regional practice, it is better to discuss with the surgeon and communicate clearly, because if an additional dose of heparin is used intraoperatively, then you may compound the problem. And whether to postpone the surgery, there is no clear mandate on this, but it is what your experience, the surgeon's experience, the patient need in an emergent surgery, you need to take a decision, and so as to optimize the patient outcome. The other type of heparin at the present day, which we all have come across, is the low microwatt heparin. And if there are 10 brands, or umpteen number of brands available in the market, and each one of them says that this erdapirin is better than enoxaparin, enoxaparin better than argiparin. But all said and done, they have certain things. They have a long half-life, and most of them are excreted renally. So any patients who have renal insufficiencies, the duration of action of LMWs is prolonged, activity is prolonged, and you may have a cumulative activity which may not come down normally within the desired time. So the mechanism of action is same, factor 10 inhibition, and that's how they minimize the incidence of DVT, and has its anticoagulant effect. But when the LMW was introduced for the first time in mid-90s and early 90s, the FDA had issued a black box warning stating that you need to put out very clearly that LMWH can cause neuraxial hematomas, and every anesthetist has to know. And there have been at least 80 cases reported within 5 years of initiation of this practice, because US and UK, US people are more aggressive, UK are a little more complacent. In US, the strategy they follow is 1 mg or 0.5 milligrams given 12th hourly, whereas in UK they give 0.5 milligrams every 24 hours. The incidence of neuraxial hematoma is relatively less in Europe when compared to that in US. But again, when you see the incidence of DVT and VT, there is not much of a difference in consensus. So there is no uniformity on the consensus of the usage of heparin worldwide, and we need to have ahead, and we need to have this. Again, if you have a patient who is receiving LMWH and whom you contemplate to use regional, what should be the ideal time before you do regional safely? If the patient is on a prophylactic dose, then 12 hours, 10 to 12 hours of stopping of heparin and doing the procedure is quite safe. Like most of the societies, they recommend 10 to 12 hours, and we also have the same protocol. And if the patient is on a therapeutic regime, like if the patient receives 1 milligram per kg every 12th hourly, then you need to wait for 24 hours before you contemplate a safe regional. And it is prudent that you remove the catheter at the end of the surgery, because this patient is going to go back again on the therapeutic regimen. It is very important. And always anticipate increased blood loss, and see that you are appropriately geared up to tackle other complications. Again, what should be the interval of reinitiating heparin post-operatively? It all depends on what type of surgery the patient underwent, and what type of how was the procedure. If the procedure was you had a bloody tap, then it is better to postpone the heparin by 24 hours, and see that the patient receives alternate methodology of DVT prophylaxis, like mechanical devices should be in place. And there's a very beautiful article, I'm sure it's freely available on the web, and you need to know that if the patient is on higher dosage of heparin, then concurrent medications, NSAIDs, you have to be used cautiously so as to prevent major patient morbidity. And again, indwelling neuraxial catheter, if the patient, is it safe to provide postoperative analgesia? Yes, if the patient is on prophylactic dose, you can retain the catheter, you can provide safely the postoperative analgesia, and see that the catheter removal also is planned. That is, you give a gap of at least 12 hours, 10 to 12 hours between the dose and the catheter removal, and once the catheter is removed, give a gap of at least 2 to 4 hours before reinitiate the LMWS therapy. So, as already I have said about this, if the patient is on thrombolytic or fibrinolytic medications, how do you go about? Well, there are no original recommendations as to withhold neuraxial block for 10 days, but there is no data to say that you need to wait for this many days, and there is positive data on this area. But all said and done, for some reason, if the patient has received regional anesthesia and the patient goes on receiving thrombolytic agents, like say for thromboembolism or myocardial infarction, then you need to monitor the patient very closely. The patient has to be on the safety net. And if the patient has an epidural catheter, better not touch it till the patient has normal profiles, at least about 24 to 48 hours. And vigilance is utmost important. Herbal preparations, as I said, the ginseng, the garlic, the ginger, they inhibit platelets, they inhibit coumarin, they activate or they have coumarin-like activity, and they may all affect or act perioperatively to worsen the anticoagulation and can have drug reactions which can sometimes cause neuraxial hematomas. Because they don't have a clear-cut data, and most of the patients generally we ask them to stop at least a week before, and see that if the patient receives any concomitant medications against geriatric age group, many of them they receive NSAIDs, COX-1 and COX-2 inhibitors. You need to titrate the dosage appropriately and assess the patient for any bleeding tendency. Fondaparinux is another newer agent, especially the HIT entity has become such a common thing now in several ICUs. They have stopped using unfractionated heparin, they moved on to low mercury heparin. And the primary HIT and the secondary HIT, one of the drug of choice is fondaparinux. And when again you have a patient with fondaparinux, the safe limit is not defined, but if the dosage is less than 3 milligrams, then 48 hours of waiting is good. And if the dosage is more than 3 or more than 5 milligrams per day, then you need to wait for at least a week's time before you give any neuraxial blocks. There are again thrombin inhibitors in market, bilirubin and lepirudin, which again are recommended for heparin-induced thrombocytopenia. As I said, several medications are used, and it's better you go through the respective drug literature before you plan your regional. And if you see the anticoagulation peripheral nerve blockade, generally, fortunately, the neuraxial injuries are relatively less because the peripheral nerves are in the large compartment. The actual nerve compression is less when there is an expanding hematoma, because when the major difference between PNB and CNB, the peripheral nerve block and the central neuraxial block, is expandable versus non-expandable compartments. And whenever you have an expandable compartment, you may see more blood loss, less patient morbidity. Of course, you may see more blood transfusions, but good patient outcome. And you need to keep this in mind. So whenever you're giving a neuraxial block, you need to know which nerve you're giving and what is the area, in case if there is an inadvertent bleeding around the nerve, is the nerve compromised, is the injury going to be fatal, and you need to keep this monitoring very carefully. If you have a patient who is on anticoagulants, who is for emergency surgery, and you contemplate to use regional, how do you go about? Well, the first and foremost important thing is review all medications, concurrent medications, and if the patient is having coronary stents, is it a bare metallic stent, is it a drug-eluting stent, and when was the stent put? Is it more than 12 months, you are safe. If it is less than 12 months, drug-eluting stent, again you are not safe, because coronary thrombosis is very common if you stop antiplatelet medications. Prostatic valve, what type of valve the patient has? Is it a tilting disc valve, is it a ball and cage valve, or it's a St. Jude's prosthesis which is less thrombogenic? You need to keep this in mind. It will take 2 minutes. Risk versus benefit, you always have to analyze the risk versus benefit, the GA versus regional versus combined general regional, risk versus benefit of discontinuation of anticoagulants and the risk of thrombosis. So always you are on a tightrope. You have to balance what is good for the patient, what is good for you, and what is good for the hospital. So you don't have to induce a major patient morbidity when you have a simple airway who patient is fasting and do a heroic regional. So you need to have a multidisciplinary liaison with this and strategic planning. You need to have a liaison with cardiologist if the patient is having coronary stents and prosthetic valves, so that you can titrate appropriately and give what is best to the patient. Well, if several times you have a patient combination with all these medications, you need to remember that what tests you would like to do before the patient comes for surgery. The tests that are recommended before the patient comes for surgery and the patient were on anticoagulants, if the patient is on unfractionated heparin, go for APDT. Can I take one more minute? Yeah. If the patient is on platelets, you can, if the patient is on unfractionated heparin or a low molecular weight heparin, both can cause thrombocytopenia. Platelet count is advisable. PTINR for warfarin, but no additional tests are recommended if the patient is on antiplatelet agents, LMWH, NSAIDs or fondaparinux, because many a times, many of our colleagues, anesthetic colleagues, the moment the patient is on Clexane or aspirin, they advise BT, CT, PT, ABDT, which is not of any use. Whether factor Xa inhibition assay is important, yes, it may be important to monitor the therapeutic assays and therapeutic levels of anticoagulants in the plasma, but it does not predict the incidence of neuraxial hematomas or peripheral nerve hematomas. So factor Xa inhibition assay also is not recommended. Neither TEG, that is thromboelastography, is predict the incidence of hematoma. So they are all not very useful. You just have to go by what the literature says and what your experience says. And if the patient is having any abnormal pathophysiology which causes DIC or which tends to lead DIC, then you need to do appropriate coagulation profile. The major bleeding sites can be anywhere, and you need to know that there are risk factors for major bleeds and how to reverse your anticoagulants before major surgery. If the patient is on fractional heparin, on IV heparin, emergent surgery, then you can always give protamine sulfate, but remember the protamine can cause severe anaphylactic reaction and you need to do this in an ICU setting. LMWH, protamine does not work. Warfarin, if it is an emergent surgery, you can give vitamin K and you can give prothrombin-rich complex concentrate, which is quite safe, but again you need to balance the thrombotic risk versus risk of neuraxial hematomas. Again, as I said, LMWH protamine doesn't work, and whether you want to give epidural versus intrathecal versus peripheral nerve block, you need to decide what is good for the patient. And as I said, incidence of neuraxial hematomas and peripheral nerve hematomas is very rare, but when it happens, it can be very devastating. And there are several reasons for epidural hematoma, which can be related to patient. Dr. Rajshekhar already has seen the patient factors, the environmental factors, the operator factors, equipment factors, and you need to analyze each and everything. And you need to have a risk management strategy in your hospital, wherein every patient who is on anticoagulants, and when you are doing a regional, you need to keep this patient under the safety net, wherein you need to identify a problem of hematoma very early in onset, so that you can take appropriate intervention of diagnosing it, investigating it, and then treating it by either appropriate neurological intervention. Again, there is a confusing consensus. If you see the ASRA guidelines 2010, if you see read the article, they say the post-operative time interval between the single dose regime and prophylactic is 6 to 8 hours, and when it comes to cesareans, they say it's 12 hours after surgery. So even in the same guideline, if you see read the objective section, obstetric section and surgical patient section, there is difference of opinion. The confusion continues, but we need to have a safe path, a safe journey, so that you maximize the patient outcome, improve the patient outcome, and you need to have a safety net wherein if at all you have any problem, you diagnose it early and intervene appropriately, so that you can prevent any major morbidity. So there is no single cookbook recipe that is appropriate for all things. You need to have safety net. There is no second thought on it, and it is just how you alter the difficulties and you alter yourself to meet the difficulty. And we presume that within a year, AORA will come out with its own guidelines. Thank you.